We move on to the next talk.
Yeah, thank you so much. Actually, I would like to say that Dr. Hitya sir was my HOD, and now he's chief. And I still had those VHS and CDs that content this circuit. So I think we all learned from those. And I think, like Madam said, I have nothing more to add after your lecture actually. But still, I would like to just maybe few points might be additional. So I will just run through my presentation, and I think it will be more useful for all of us if we have a more panel discussion, I would say. So, clinical training program and how to refine it. I am Dr. Sourav. I am director of AIOC2023 PG Institute, Sangli, Maharashtra. So this scope actually it includes all the TMPs as well as fellows and short-term trainings. So whenever you think of training, it should have four different parts which should be covered in your training program. So first will be academic, next will be clinical, third will be the surgical, and then the research and presentation. So in academic, basically it means to know about the theory, because what we find is that if the student or any resident or fellow who has come to you for any training and he doesn't know anything about theory, it's very difficult to train them, because you are showing them a certain sign and they cannot see it, because if mind doesn't know, you cannot see. So it's very important to take regular classes. Nowadays we have advantage that we can take a lot of online classes also. We can invite faculty from various institutes and they can take online classes very easily. Weekly and monthly classes schedule should be prepared. So what we generally do is that we have a yearly schedule of lectures which have to be taken, and it should connect have all specialties included in that. And every year we will repeat it, maybe few variations here and there. So what happens, even if there is a first year training or second year training, we make sure that they have touched all the subspecialties in that year. So this includes presentations, lectures, and very useful, like Dr. Munawar sir was previously saying, journal clubs. So cover all topics. Do not miss the basics also, optics and basic sciences. And what we do nowadays is that we ask our resident to teach the optometry student. We have optometry school, so we ask them that you take lectures for them in optics and basics. So that way both things happen. They also learn and they have the art of presenting and teaching others, which is very important. This is one more part which I think has to be done, because what we have seen is that students just prepare at the last minute when the exams are coming up, and all throughout their 2-3 years of post graduation or fellowship they will not learn, or they will not sit and read about things. So take written exams and viva every 6 months, so they are always prepared. Our state society had these journal club presentations every month last year. So our students also participated in that. It's a good activities on maybe AIS or state or even district societies to do this, conduct these online courses for various theory as well as journal club, which is very important. Now for clinical and practical experiences, what are the ways you can train? So first, most importantly, initial part of the post-graduation or fellowship is observation. So make sure that your facility has these video cameras attached to your slit lab. Many times what happens, the consultant is seeing the patient. They don't have enough time to show their fellows who are standing behind. But if you have these aids, what happens that the fellow is also continuously learning, and you can discuss, you can ask him questions, what was that, or how to go about these things. As rightly pointed out in the panel discussion, start with refraction postings. I think that is the first thing we ask our students to do. First 3 months they are actually learning under the head optometrist. So rather than asking them to come to the OT and start giving block, we ask them, go to the optometrist, you learn how to do refraction first. And everything is done always under supervision. As they learn, we know that they are much better in clinical. Now they are given the exams, and now they are good. We can give them independent workups and OPDs, and also in these cases the peripheral centers are very useful, where they are all alone, so they can manage confidently. If they have any doubts, they can always do telemedicine, but they have that confidence that I can manage this patient on my own. So apart from that, what we have seen, like we are thinking about the sterilization protocol. So many times students pass through institute, but they do not go to any. For example, OCT machine is there. The technicians are doing the OCT and they are just reading the report. They will not do themselves sometimes, but it is must that you should handle all the equipments personally, including these scan, OCT, A scan, etc. So that when you go to private practice or you go to job, you know how to deal with devices. Many times, even if optometrists are using these devices, you know when they go wrong if you have done them yourself. Now, surgical training, every time, nowadays, if you ask group of, PGs or, those who want to go for fellowship, the first thing they will ask is how much cutting you get. And obviously, practically, that is what, earns you the livelihood. Okay, if you are just an academician or a clinician, you are obviously not going to earn much. So, first important thing when we start the training of a PG or a trainee, we check vision, stereopsis, do refraction of the training and check the IPD and also do orthoptic workup. We have seen like there are few trainees, we find that why they are struggling to do surgery. These are very easy steps and they are struggling. And what happens is that they generally then we don't offer them more cases because they are doing more complicated, they go back in their surgical training part. What we have found is that many of these students have orthoptic problems and that's why they are struggling to do surgery. So if you do it at the start, at the beginning, you know how to correct it and how to encourage them to go into surgical training. So first month will be obviously first orientation into different parts of the training center, even the peripheral OPD, and then in the second month we start with the dry lab. So we have certain numbers like you should do at least 50 shoe strings or 100 shoe strings or something like that before they are allowed to sit on a microscope and do simpler steps to begin with. So in the first year, we generally start with the SICS steps under supervision. They start with very low risk steps to begin with, and gradually we increase the number of steps. Now, what is important is that give them cases on a regular basis. So you can set a number, say once in 1 week or once in 2 weeks, something like that. I remember in RPC we used to have twice a week OT, and maybe we were given cases once a week or once in 2 weeks. But if you have that constant pace in your training, then generally you get better and better. Okay, so you should have a particular goal for your training program. For example, for our first year training program, what our goal is that the trainee should be able to do an independent simple SICS case. So that should be your program. So you can achieve it on the go. Also, apart from the cataract surgery, because we know when they go back to private practice, not just the cataract surgery they are going to do. They are going to do a lot of minor surgery. And if they have not done it themselves, they have just observed, they are not confident. And many times, it's best to incorporate and give steps of simple minor surgeries which are useful in private practice, like pterygium and maybe second lesion removal, etc. Now, most important in surgical training part, what I found is that we must record each and every case what the trainee or the fellow does, because every case is important. The surgeon should learn from that case by analyzing every case. So we encourage them to edit these cases, present in our weekly or weekly meetings, and we also have video discussions on surgeries including 3D. So nowadays, as Dr. Patel sir was saying, that now we have access to 3D surgical videos, which are more useful because it gives more, lifelike experience for the trainees. Now, for simple surgery, rule is simple: see one, do one, teach one. That's what we learned during RPC with your mentors or your seniors along with you. And of course, for DNP trainees or fellows, it's very important that they get the opportunity to assist other specialists. Though, for example, you are just training yourself in cataract, but you should, if you are assisted, oculoplasty surgeon or retina surgeon in his surgery, when a case comes in your OPD, at least you know, these are the procedures that are required for that particular patient. It is immensely useful for the patient if they have a doctor who knows everything about different specialties. Of course, about various institutes have their own norms, but we generally start depending on the skill in the third year, and we start with the 3D teaching course, and then we ask them to watch videos from different resources. Nowadays, there is no, I think, dearth of resources that is available. YouTube is full of videos from which the trainees can learn. So every surgeon or every trainee has this logbook with them where they have to enter everything, the patient details, etc. These are signed by the surgeon, and they are also encouraged to keep their personal handbook where they write down the complications they had, their Oscar score, and what problems they had, where the surgery was taken over by the trainer or anything like that. So this really helps, and we always go for a reverse training technique. I think there are publications on this, where we start with cortex aspiration and eye implantation first, and then we move back to the paper steps, which is really useful because then the hand-eye coordination is better and they learn quite quickly and easily. Okay, so initially there are seniors mentoring the juniors, and senior consultants will always be there around. And don't forget about research, I think already been said. So always have journal clubs. Also, like TTL sir was saying, students should be involved in a lot of other activities around the programs because they are going to be part of the society later. So they should be going for camp hosting, interact with the different patients. They should go for ICOs, social camps, social awareness program, and also in your curriculum, make sure that you train them in soft skills and also ethics in medical practice. So there should be a particular focus on teaching them on soft skills, how to counsel a patient, how to counsel an unhappy patient, what are the tricks in the OPD, what they should understand. Okay, and as I already mentioned and emphasized initially, theory exam every 6 months, practical exam, full recreation of the exam scenario every year. That is what we do for our students. And so thank you. I think I have used my time.
If I can make a small comment.
Yes, yes.
So actually, that's wonderful presentation. Just I want to make a point that usually the fellows or trainees when they come to the hospital, they always come in the mindset that we are here to take care of the patients, or basically they come in the mindset that with that thought they think they are doing a favor to the patient. Actually, it's reverse. By the time they finish their training, actually they should have the mindset that patients are doing a favor to you, because that way they're more compassionate to the patient. They actually see a person to trust the doctor with his eyes it's the biggest blessing you can have. You should be really thankful to them. But they don't realize, they think it's their right to see 10 fellows will be seeing one patient with an indirect like forever. And that's not right. You have to give breaks, talk to the patient, your request, is it okay, are you okay, can we see a little more? It's more of a requesting that has to happen from day one. The trainee should realize, and like Titi sir said, that I think everything is there in Google now, everyone's information is already there. So I would say, especially a fellow training program, you have to impart what is not there in Google. That is your primary objective. What, like in terms of those tricks and tips on how you do your surgeries, simple things like shrugging your shoulder, breathing properly, how's your table microscope height. Those are small things which people don't realize, which will affect your surgery in a major way. And also the other thing is, we have to tell them to observe the mentors, how they talk to patients. It's very important. How do you talk? Because 70% of your treatment is done with your talk itself. Then the rest is, even if your surgery is average, it's okay, but your 70% is what actually makes an impact and grows your practice.
Thank you so much. I think before Dr. Deepak just starts his presentation, excellent talk, Dr. Sourav. Being a training institute, you also have your private practice, right? So, how do you ensure that the patients don't feel that they are guinea pigs? Sometimes we say training institute है तो सब सीखने वाले try करेंगे अपने. So maybe sometimes the word spreads around that you are a training institute, but a government institute where it is already training, we know that. So how do you handle it?
So, we have to have different units for that. So even if it is in the same setup, we can't mix both the patient population. Of course, those who are coming in through the charitable setup, they already know that they are not going to be operated by the expert surgeons. They don't have that option, because in private they obviously know that this particular doctor is going to operate. But like in government hospitals also, we are not going to tell the patient that this particular surgeon will be. It's a team. One of the team members will be operating. So that is the implied consent.
And the supervision is very important. And when supervision, when we say, a lot of times you see that the mentor will just be standing there, he's operating there, mentor seeing the screen. Actually, it's not possible. If you're looking at a 2D screen, you cannot make out the depth. You have to see the training, or the mentor should see through the side viewing microscope. Then only the teaching becomes really effective. Or the 3D screen, if you have it, that is fantastic. Even you don't bend and watch it. You can look at the screen and train your fellows. I feel that is very, very crucial.
Thank you, sir.
We have the RTO system now, and it's, I think, a big boom, not only for the surgeon but even for the teachings, the distance. really fantastic it is, and I think that's going to be the future as TTL is. So